gone are the days of me saying, this is the way I do my manual work, and now I want to get into the electronic world, and let me just take my manual processes and automate them. Colleagues, it's fundamentally important that before we make those huge investments in digital, we revisit and reshape the business model itself, and do not simply take that model and say, well, here's a technology, it will automate it for me, let's move on with it. You have an opportunity today to actually look at that business model and say, what are the areas of improvement? How can I make this more efficient? More importantly, how do I make this very customer-centric, in our world, patient-centric? So you have an opportunity to take that view and look at that and say, what are the technologies and enablers that I have that can actually make me rethink and reshape that, and then go about the investment, rather than simply saying, I want to move from manual to electronic, make the investment, and then realize that you're not actually reaping those benefits. We all know some of these facts, and some of this is not new to the majority of us, but we clearly know that as populations age, life expectancy continues to increase, and that's one of our key ambitions here in our beloved nation as part of Vision 2030. Healthcare will continue to take an even larger share of GDP, so our expenses and our costs are only going to continue to rise, at least in the immediate short and medium term. Can that change over a period of time with the enablement of digital? In our world, coming from the digital landscape, we absolutely believe we can. But there's a lot of work that we need to be doing from today until we get to that stage of maturity, where we move away from curative healthcare into prevention and wellness. If we're able to focus on that in the next 5, 10, 15 years, costs should drop. But there's a lot of work we need to be doing between now and then. And that work is not just the work that us as digital technologists need to be doing. Most importantly, it's you at the forefront of the practice that need to be embracing this, enabling it, and leading the way forward. We are here to enable your business, but not drive your business. This is your business, it's your profession. You need to be at the forefront. If the two worlds and those two individuals cannot align and work hand in hand, we're really just wasting our time, wasting our money, and unfortunately impacting our patients and their health care. So there's a lot of convergence and merging going on, but most importantly, fact number 4 that you see there is our patients, our payers, our providers, and the producers are becoming what we refer to as super consumers. The level of intellect, the level of knowledge they have today more than ever is only getting higher and higher and increasing. The discussions that we have with our patients and our consumers today are more intellectual than they were 10 years ago. They are more informed. In some cases, the patients come in with information that sometimes we don't even know what they're talking about, where they got it from. So what are we doing to remain steps ahead of our patients and our consumers rather than lagging behind? So there's a lot of various interventions, education, awareness that we need to be taking on ourselves if we want to remain ahead of the game here, team. So when we look at the patient-centric health ecosystem, we see convergence between the payer side, the provider side, other ecosystem partners, and most importantly and fundamentally, this all revolves around that one single target in the middle, which is our consumer, our patient. But we notice that a lot of convergence is happening. And the digital innovations that we are seeing, that you see on the right there, in some cases are some examples. But today we have data and analytics, and I know some of the speakers after me will be zooming in on some of that detail. We look at the aspect of personalization. Today more than ever, the amount of data that we have, we are able to no longer say, well, what is the general view of the world and what's the one-size-fits-all solution here, which we know is not the case. How do I develop a solution and an intervention that can target you as a specific patient or as a specific consumer? The amount of data that we are able to grasp, and we have, but unfortunately we don't do much with, or we don't capture correctly, or we don't structure correctly, but if we did all of that, the amount of data and the vast data we have will only help you go about your lives in a more proactive manner, and more importantly, hopefully impact your population in a much more positive manner. But we look at technologies like the new Apple Watch that was released several months ago. You know, who would have ever imagined 10 years ago that a patient at home could actually go about doing an ECG within their own household, right? Personally, I would have never thought that I would have seen that in such a very fast period of time. That is the reality of today. It's no longer a dream. It's no longer something that we say it can happen. It has happened. And what's going to come is even more than that. Some things that we probably aren't even thinking of today, and we'll be surprised with them in the next year or 2 years. So once again, how do we remain ahead of the curve? How do we remain leading at the forefront? And today, more than ever, as a nation in the kingdom, we should be extremely proud of our ambition, of our drive, of the support and the level of resources we have. There is nothing stopping us as a nation to be at the forefront of leading digital within the healthcare space. The only thing stopping that from happening is all of us. And whether we want to do something about it or not, and whether we want to be leading at the forefront or not, and whether we want to be working together collectively as one team with one focus on one goal, which is ultimately the patient and the consumer and the well-being of our society. But there's nothing else that's stopping us from doing that. The digital landscape, and one example that you have here, Mercy Virtual, is a 100% digital-based facility. So there's no beds in it. When will come the day where hopefully here within the kingdom very soon we'll be able to say we actually have a digital facility and a digital hospital? But on the flip side of all of this, colleagues, I don't want to make it sound or seem like, digital will solve all of our problems and won't create any challenges. It will, right? When we talk about data, when we talk about information, we need to start thinking about security. We need to start thinking about privacy. We need to start talking about what is the level of information literacy that the consumer has, that with all this vast level of information, am I not making them anxious? Because that's what we refer to as the unintended consequences, which is, yes, our goal and our intention is positive, but unfortunately sometimes there are unintended consequences that only negatively impact our consumers and our patients. And in our case here, if we're looking at our patients in the cardiac world, anxiety and stress is fundamentally important for us to manage as well. So we don't want to get our patients and our consumers also at a position where they get nervous or anxious because a piece of information or alert comes onto their table. So there's a balancing act that we need to go about. But once again, if the professionals of both those worlds come together and work hand in hand, we can absolutely create something that's very effective. I will hopefully conclude on this slide, and this is where we're heading, ladies and gentlemen. And this is not where we're heading in the kingdom. This is where the world of healthcare is moving across the world, and some countries are more advanced, and we are hopefully on the right road and roadmap to get there and achieve this, if once again we put our hands together and work together as one team. But most of us within the healthcare space are familiar with stages 3, 4, and 5, and that's primary upwards. When we look at the world of digital, we believe that there's actually 3 new stages that are being formed today. And they're only being formed with the leverage of digital and technologies. Level 0 is where we've always been talking about prevention and wellness. But we've always been talking about it as we know it's important, we know we need to do something about it. We know that from a public health perspective and awareness perspective, we need to do something. But today, with the advent of technology and digital enablement, we can absolutely empower our consumers, empower our providers to go about more effective prevention and well-being. When we look at what we're doing in the kingdom in terms of shifting the model of care, those of you that are exposed to the aspects and the pillars of Vision 2030 as it relates to what we're doing across the Ministry of Health and other healthcare organizations, the shift in the landscape of the model of care, the shift in the landscape of our providers moving away from a government being a government-run operations to becoming more of a corporatized environment will only hopefully enable them to create the right level of incentives and put in the right level of investments to go about what they need to be achieving here. But part of this is looking at that primary care and underneath. So when we look at stage 1 and self-monitoring at home, today with sensors, with IoT, with robotics, I can actually live in my household, and the sensors around me can actually capture the data, monitor what I'm doing, monitor my movement, and proactively send the right level of alerts to the right level of individuals in order to proactively come back and resolve my case or help me go about my case. That didn't exist a number of years ago. So what we believe is, when you look at the world of tomorrow at the bottom there, in the digital healthcare ecosystem, that the digital landscape will fundamentally, hopefully, enable stages 0 all the way up until even a portion of stage 3 or level 3. And hopefully with time, what we are expecting is that pyramid where today our pyramid is upside down and inverted. Most of our population is focused on tertiary and quaternary. And when we go down, that pyramid is upside down and the minority are going through primary care. Hopefully with the advent and the digital revolution, one can only hope and aspire that that pyramid will finally be shifted, that base will become the true base, but even that base and the access of that base will be able to be achieved within your home, within your fingertips, within your own technology devices and your mobile devices. Colleagues, it's been a pleasure being with you all this morning. I have a lot more that I wanted to share, but I know I'm running out of time as well. So once again, I wish you all the best, but I hope all of us can really just think about one question and one question only, which is, what do I need to be doing to better drive this agenda forward, knowing the benefits that I can reap, most importantly and fundamentally for our consumers, our people, our kingdom, our society. Because if we can become a healthier nation, we become a healthier economy, we become a smarter economy, and we become a more productive economy. So let's not lose sight of that. Let's take advantage of this opportunity, and let's work hand in hand. Thank you very much.
Thank you very much, Fadi Buhayran. And our next speaker is our colleague, Memes. Memes, he's a physician, he is an interventional cardiologist from UK. He will talk to us about personalized medicine and the big roles for the big data and the machine learning. Dr. Memes.
So, thank you, colleagues, for inviting me. My name is Memes Memes. I'm Professor of Cardiology at Keele University in the United Kingdom. I'd like to extend warm thanks to my friends and colleagues, Professor Al-Fallah and Professor Balgaith, for inviting me to this very important session. So, precision medicine, is this a new thing? We're talking about personalizing care for patients. But precision medicine's been something that we've done for over 100 years. This is Ruben Ottenberg of Mount Sinai. He practiced precision medicine. He was the first to record testing, cross-matching a patient and a donor for a blood transfusion. What do we mean by precision medicine, though? Precision medicine is customization of healthcare. So medical decisions, treatments, or practices are tailored to the individual patient using information. And the sorts of information that we use are biological information, clinical information, the age of the patient, the gender of the patient, the comorbidities, and so forth. But what do we need for precision medicine? What do we need in the 21st century for precision medicine to be able to individualize the care of our patients? Well, first and foremost, we need information about their age, their comorbidity. We need information about biochemistry, molecular markers, genetic markers. And we need this information to be readily available and accessible. We need a risk stratification tool, a tool that we can use to predict outcomes of these patients. We can predict the risk of a treatment versus the benefit of a treatment. And we have these tools. We have them for atrial fibrillation. So for example, in atrial fibrillation, you have a tool called the CHA2DS2-VASc score that enables you to predict risk of ischemic stroke complications. You have a tool that can predict bleeding complications. And these are derived from registries. We have other tools like the Framingham Risk Score, and this uses one or two risk factors such as total cholesterol, smoking, diabetes, that can predict your risk, and then that can personalize your treatment about whether to receive a statin or not, whether to receive primary prevention or not. But the problem with all of these tools that we use today is that they focus only on one or two comorbidities. For example, the Framingham score focuses on diabetes, on hypertension, on cholesterol. But what about all the other comorbidities? You know, there's much more comorbidities that we need to consider in terms of personalizing our approach to patients rather than a cluster of 3 or 4 cardiovascular risk factors. We also need to consider a change in risk factor profile over time. This was a picture of me when I was 3. This is a picture of me when I'm 45. I've changed. You know, our risk factors change. They're dynamic. It's not something, you know, how can you look at a patient's risk factors today and then hope to predict what's going to happen to them in 10 years' time or in 20 years' time? You know, you may gain weight, you may stop smoking, you may have a heart attack. You know, these things all change. In Saudi, you know, your population is very different from the traditional risk factors from which the scores were derived. So taking the Framingham score, I mean, you know, in your over 60s, over 60, 70% of your patients are diabetic. Your patients are 20 years younger than the average age of those derived from the Framingham risk score. So why should the Framingham risk score be useful in Saudi patients? It probably isn't. And so in terms of personalizing approaches in practice, we need to make them patient-specific, population-specific. Many of the risk scores are derived from randomized controlled trials. So for example, our decision to revascularize patients is derived from a small randomized controlled trial to create the syntax score. And on the basis of the syntax score, we have recommendations. You know, if you're a very high score, you go for surgery. If you're low score, you go for PCI. But who's recruited in these trials? You know, the average age of patients is often 10, 20 years younger than the sorts of patients that we see every day, the comorbid patients, the frail patients. You know, the ESC guidelines talk about presence of severe comorbidity or frailty in informing our decisions. But what does these mean? What does it mean, severe comorbidity? You know, in terms of having a cath even, again, if appropriate, if they have severe comorbidity, if they have frailty. You know, does severe comorbidity mean that they're diabetic? Does it mean that they're diabetic and hypertensive? What do we mean by comorbidity? And this is where I think electronic healthcare data and big data comes in that it offers us solutions to all these problems. First and foremost, it's region-specific. You know, we're not considering using data from the US or Framingham or from the United Kingdom where I'm from, but you're able to use data from your local population. It captures all aspects of healthcare. It's not just whether a patient's diabetic or whether they're hypertensive. It provides more information, you know, frailty markers. It provides information about whether they've had cancer, other operations, and so forth. It's more holistic. It's longitudinal. It's not a snapshot in time. Many of the risk scores that we use are just a single snapshot of information collected on a particular day. A healthcare record follows you in the lifetime of the patient, and so you can use this information, this longitudinal information. And it provides information across all healthcare providers. So to develop a risk score, you need to capture outcomes. And in the United Kingdom, we have started capturing outcomes such as mortality. This is a risk score that my group published in PCI. But it's not just about capturing mortality outcomes, it's capturing complications, things that are actually more important to patients. Many randomized controlled trials recruit healthy patients, and so the complication rates are very low. The Syntrax trial, there were 7 strokes. What will that tell us about complications? Nothing. So we have to use, routinely collected healthcare data, longitudinal data. And we can capture this. So we've published a whole load of publications around complications of PCI and incorporated these in the risk models that we've developed, such as stroke, bleeding complications, retroperitoneal complications, coronary perforation, and so forth. But big data is also important in that it enables us to capture much more holistic picture of the patient. It's not just about whether they have diabetes, it's not just about whether they're hypertensive, but thinking about the patient in a more holistic manner. And so, there are measures of comorbidity. So the Charlson score, for example, captures 22 different comorbid conditions that are never captured in prospective registries or randomized controlled trials. You can gain this information from routinely collected healthcare records. You can look at how this changes over time. And we've done that in the United States. We've analyzed 6 million patients undergoing PCI procedures. And only 1 in 3 of these procedures in 2014 had no comorbid conditions. 2/3 of the patients we treat are comorbid, are multimorbid. This provides us important prognostic information. Comorbidity impacts on outcome, and yet we're not using this information. Frailty, what do we mean by frailty? Guidelines tell us to consider frailty. But what do we mean? We don't capture it, but again, using electronic healthcare records and big data, we can capture frailty. And you can see that in PCI, frailty increases the risk of adverse complications. So if you're frail, 1 in 4 patients undergoing PCI in contemporary practice will have a bleeding complication. 1 in 6 will die. This provides important prognostic information. And even when you adjust for differences in outcomes, if you're frail, you have a 7-fold increase in the risk of mortality. You have an almost 10-fold increase in the risk of bleeding. This is important. And so we use this information to develop a risk tool. But are these risk tools appropriate? I don't think so. Why? Well, because patient characteristics change, the way we do things change, and the performance of risk tools drops. So this is a risk tool looking at risks associated with cardiac surgery. And over time, the predicted risk has increased, but actually the observed risk has decreased. On the right-hand panel, you can see that if the risk tool was perfect, you'd have a straight line. But you can see over time the performance drops off. So over time, our risk tools become less effective unless you update them. There's drift. And they're already out of date when you've published them. This is, my group's published the UK TAVI risk score. It's great, everybody in the UK uses it. Is it useful? I don't know, because it's outdated. The data that we used to develop this was between 2009 and 2014. I published this risk tool a year ago. The data that's informed it was 10 years old. This is data. We don't use half the valves that were used 10 years ago in this procedure. We don't use the techniques that we used. So how is this risk tool going to help us in our practice? Another risk tool that I published was for PCI. I used 2006 to 2012 data. So how can we get around this? How can we improve our personalization of healthcare? Well, currently, the way we develop risk tools is what I've been doing, what my group's been doing, where someone sends the data to me, my statisticians work, develop a risk tool, we use it for 5-10 years, and then we update it. But that's not really personalized medicine because the risk tool does not work. It drifts. The performance declines. And so what we should be doing is utilizing digital health, utilizing software, utilizing machine learning, and being able to upload this information in real time, have the risk model update itself in real time, and so that you can accurately predict risk, not predict what you think it may have been 10 years ago, but predict it here and now. And why are we just using electronic healthcare record data? We have Apple Watches, we have digital wearables. These provide important information to us. It provides information about patient function, how much activity they're able to do. This will improve our risk prediction. Having a patient that's ambulatory is probably one of the strongest predictors of outcomes in the procedures that we do, for example, TAVR procedures. Being able to capture atrial fibrillation, capture other cardiac conduction events, capture activity, that will improve the prediction modeling that we undertake. Imaging data, we undertake images every day, whether it be a heart scan, whether it be a CT scan, whether it be an MR scan, whether it be an angiogram or OCT data. Why don't we use this information? We capture, blood tests, a metabolome, proteome, transcriptome. We do ECGs every day. How do we integrate all this information to personalize medicine? It's not just about, whether you've had diabetes, whether you've got atrial fibrillation, whether you're hypertensive, but taking all information, taking information around images, ECGs, genetic information, wearable information, and integrating this into our risk prediction models. How do we do this? Well, we've had huge advances in computing software. When I was a child, the computers that we were using are probably much less powerful than the calculators that we use today. And so we should take advantage of this information, take advantage of this computing power. And we've started to do that through machine learning. So what do we mean by learning? Well, learning is a process whereby you improve your performance through experience. And we can do this with computing. So we can generate computer algorithms that automatically improve their performance through experience. And we can use these computer algorithms to generate prognosis risk models using information from different arenas, from electronic healthcare records that's longitudinal, from images, from wearables, and so forth. And we can have different types of machine learning. So you can have supervised learning, whereby you start with a known output. So you start, say, with an abnormal chest X-ray, and you train the computer and their algorithms to predict this abnormal chest X-ray. Or you can have unsupervised learning, where there are no outputs to predict. Basically, you put all the data into your model, and then the computer algorithms find different patterns, different phenotypes of patients. And then you can look at these and how they relate to prognosis. That is the future. And we've used it. We've started to do this. We're at the very early stages, but I predict that the traditional ways of developing risk scores, like myself and other people have used, will be, not fit for purpose. Could we carry on? We have, deep learning for predicting in-hospital cardiac arrest. We have machine learning for predicting all-cause mortality in patients undergoing cardiac CT. And so, in my view, the way that we're going to personalize medicine is not using traditional risk scores derived from a few hundred patients or a few thousand patients in a registry, but rather using electronic healthcare records, your index event, looking at these longitudinally, looking at how the patient condition changes over time, but using information from digital wearables, using information from imaging, from echoes, from ECGs, using information from the metabolome, proteome, transcriptome, and using machine learning, most likely unsupervised machine learning, in real time to continuously update these risk models that we use so that we can target effective treatment. I think the important thing about personalized medicine is whether the information is actionable. So this is Cassandra from ancient Greek mythology. My background is Greek, so I use Cassandra as an example. So the gods gave her the power to predict the future, but she could do nothing about it. So she predicted the fall of Troy, but she could do nothing about it. And she became mad because she could see what was going to happen, but had no power to impact on it. And so my questions for personalized medicine are this: is the information actionable? Can you do something about it? There's no point in being able to predict prognosis if you cannot do anything about it. You know, always think, is there a therapeutic target? Can you intervene on this therapeutic target and change the outcome? And are these outcomes better than a one-size-fits-all approach? You know, if we just give the same medication to everybody, irrespective of their background, are the outcomes no worse than trying to personalize? And these are the sorts of questions that we really need to start to dissect out and think about when trying to personalize medicine. So I think, in summary, routinely collected healthcare data is used to personalize treatment. We do this all the time: risk stratification, treatment of choice, duration of treatment. But moving forwards, we have to consider other sources of data to inform these risk prediction models. So, for example, wearable devices, systems biology, imaging data. We need to update these models at the population level where they're going to be used, but in real time. Otherwise, they're going to drift and they're not going to be fit for purpose. And the most important thing to bear in mind is this information actionable? So I'd like to thank the Saudi Heart Association for this great opportunity. I'd like to congratulate them on this superb meeting, and I thank you for your attention. Thank you.
Superb talk. We will be moving on to the next speaker, Dr. Amr Jamal, who is going to talk about how would the digital technology or digital revolution impact the job market in healthcare. Dr. Amr.
Is it ready? Assalamu alaikum wa rahmatullahi wa barakatuh. Alhamdulillah wa salatu wa salam ala rasulillah wa ala alihi wa sahbihi wa ala. Thank you for the invitation. Thank you, Dr. Hussam and the organizing committee for inviting me for this well-known conference that has been repeated for the last 30 years. My talk today about the digital revolution. Is it going to affect our jobs as healthcare providers, which is a trending and important topic for us today? Are these technologies that we heard from Fadi and Mamas will affect our future? What is the controller? Great, thank you. So, at the beginning, as a disclosure of, I don't have any conflict of interest. I work for King Saud University and the Saudi Commission for Health Specialties, so there is no conflict of interest for me. So, the evolving technology and big data, robotics, and artificial intelligence, is that we're going to replace us as, so there's no pointer. Is that to go to replace us as a healthcare providers? Or no? I think, and it's no. And we'll show you why. And that has been repeated through the history in many revolutions that we have in the past. In the Saudi Commission for Health Specialties last year, we have got big study about the health workforce and the trend for the coming 10 years. And we have got more demand that we have in all aspects, with the attrition rate that we have in the current health sciences students, including physicians, nurses, dentistry, pharmacologists, with the undergraduate and postgraduate studies, including the Saudis and non-Saudis, and the population increase rate that we have in Saudi, which is 2.7, or exactly 2.67 annually. This is show us that in a state of the last 15 years in the United States, this is the unemployment rate. There is no big changes, except that in the drop that they have in the, well, actually, this is unemployment, the increase in 2008 and 2009 because of the financial crisis at that time. Although that many of the jobs has been, that had been changed. So, for example, 50 years ago, 40% of the US population were working in the agricultural farmers, and now it's less than 2% of them. Why? Because of the automation process of many of the agricultural process that they have. This is a tweet that we had just last week from the Minister of the Communications. So the robot will take over in many of the aspects of the healthcare, and the clinical consultation will cost less than 1 Saudi riyal. Is that true? We will see. We remember 15 years ago that we have in the job markets over here that, who remember these, the called cabins, kabain al-ittisalat. So at that time, when the introduction of the mobile phones, and the reduction of the cost of the calls, that it was predicted that 16,000 will be unemployed because they were working at that market. But that happened? No. Only that they changed the market. So those who were working in these calling cabins, they changed their markets to other, for example, the mobile phones markets. We remember also the banks, how they were crowded 5 years ago, but now that has been replaced by the technology, using the online, the mobile devices, and many of the things that you have to go outside of your home to do it, that you can do it at the point of spot, or from the healthcare providers at the point of the care, that without our movements. We remember before the PACS implementation in 1999. That's many of the skills that we need to know as a physicians, how to use them, that has been changed, and we have to learn new skills, how to deal with the PACS systems. So we have to adopt with the new changes in the technologies that we have, not to lose the market. The future of radiology augmented with artificial intelligence. It has been said before that 5 years ago, that after 5 years, that we will not need any general radiologists. And the imaging processing and artificial intelligence will replace the general radiologists. However, we still need radiologists because of the change of the new skills that we have them in the future. So why still we have more healthcare jobs? Because of two phenomena. The first one is the human creativity. So we have got new creative trending things. For example, the blockchain concept. 2 years ago, nobody was talking about them, but now they have been changed from the financial and Bitcoin business to the health business. And also that the human insatiability or the greed. So we don't have never enough. So for example, if we have got robotics, I remember even in the cardiology. So many of the procedures that have been done before by the cardiac surgeons moved to cardiologists, and many of the major invasive procedures has been moved to minimal invasive procedures. So we have got new market and new market for the new businesses that we have in all aspects of that. So what the technologies that could affect the healthcare jobs? They can be divided into 3 categories, including the digital medicine, the genomics reading, and in the future writing, and also the artificial intelligence, including robotics and machine learning. And that's in the study that has been published 2 weeks ago by the NHS. showed us that they're preparing to the healthcare workforce to deliver the digital future by the NHS in February 2019. They showed us how much of these technologies are going to affect the healthcare workforce or the job market. The most of that they're affecting is reading the genome and the personalized medicine using the databases of genomes. How are they going to affect the healthcare jobs? And the minimal one is the writing the genome, which is going to be predicted within the coming 20 years. But the telemedicine has been implemented currently, and we can deliver virtual consultation and virtual approach to the patient using the telemedicine, and also the smartphone apps where we can target the patients at their places, at their homes, and the sensors and wearable devices and use of the Internet of Things to collect data and remind and alert and intervene at the point of care at the right time. Also, the speech recognition and the natural language processing, that's affecting many of the jobs in the healthcare market. The virtual and augmented reality and how that can be affected, where we have got virtual hospitals, virtual clinics, and implement virtual consultation with the patients in no time. Automated image interpretation using the artificial intelligence. So the skills that we have to do before, for example, the ECG that we were taught in the medical schools, nowadays that the artificial intelligence are more capable than many human beings to interpret these ECGs. So automated the image interpretation using the artificial intelligence. And the interventional and intervention robotics. So using, and now this is a reality, many of the, are we going to need the open heart surgery in the coming 5 to 10 years? Many of the open heart surgeries that have been done can be done by microscopic robotics surgery with minimal invasive procedures. And this is a reality right now. Predictive analytics using the artificial intelligence, and as said by the MAMAS, the analytics of the big data is not only to understand what had happened before, it's all even to predict and prescribe solutions that we can have in the futures. And the future is, now they are talking about how to correct some of the diseases and using the writing of the genomes. And this is one of the cases. The report is around 50 pages. One of the cases about the use of the artificial intelligence in reading the radiology. And this is a reality right now in the mammogram, for example, where you can have the mammogram with the interpretation directly. Now, although that is a 10 years study, talking about the fundamental theorem of informatics, so the goal of informatics is not to replace the human brain or the doctor brain with computer and technology. No, we are thinking about a physician working alone or physician supported with the new technologies tools. So we think about the artificial intelligence as a tool that help us as healthcare providers to have our work effectively and efficiently. So we have to have mechanism in place to ensure that the advanced technology does not dehumanize medicine. It should not dehumanize the patient-doctor counteract. And also, while automation will improve the efficiency, it should not replace the human interaction. We have now, it didn't happen before in the history of medicine, that the sources that we have are tremendous, so including the genomes, the social behavioral, and also what we have in the literature and the medical, and all of the available in the electronic health record and the personalized health record, and the Internet of Things, that can all of that collected and interpreted to have virtual health guidance that guide us as a physicians and our patients. I love this slide. This is if you didn't take from this presentation except this slide, It's by Eisenbach. That has been published in 2010 in the Journal of Internet Health Research. So the physicians were named in our Arab countries as Al-Hakim. صح ولا لا? Al-Hakim was the only source of knowledge. And that has been from the time of Hippocrates until recent days. So we are, as a physicians, we have to cope with the overwhelming data that we have in knowledge, and the patients, they have to cope with the insufficiency sources of information. And we have, this is the holy land of knowledge. So we just deal with the patients as consumers, and we give them the orders and we give them the orders about their health. Then in the 1960s and 70s came the Consumers Protection Act, حماية المستهلك, and at that time we heard about the health education. So we found at that time that if we educate our patients about their health, that they will become more responsible about their health, and their health will be better. Then we have the access of the internet. For the first time of the history of medicine, that both the healthcare provider and the patients, they have got equal access to the knowledge sources. And I remember the date in 1997. In 1996, until 1996, the PubMed, the midline, it's only restricted to professionals. And I remember at that time, I was a third-year medical student. If we need to have research, we go to the library and give them our keywords, and then they search in the CDs that they came from National Library of Medicine in the US, and they just give us the headlines of the citations. But in 1997, that it has been open for all of the public, and the annual search per year has been jumped from 7 million to 120 million. And most of that is by non-professionals. How many of you, during their clinics, the patients came with new concept or new information about their specialties that they heard from Twitter, from WhatsApp, or social media? That's new medication or new procedures that they heard about. So what's the solution? How to come ahead of our patients? Do we need to come ahead of our patients? We could not, because they have got an equal access with us. So the solutions is in the individual base and the public base that we have to, just give me a few minutes. So we have to guide our patients about the authentic sources, reliable sources, and empower them to take care of their health. For example, one of the new technologies, the drones, and how can that be implemented in medicine, and how to deliver. For example, we have got crash carts using the drones or deliver of medications. An evolving healthcare workforce need to have new competences that the new generation need to impress and to be trained off, and that should be implemented in the longitudinal continuous professional development, and also in the undergraduate and postgraduate programs. So in all specialties, they need to know more about genomics and the digital literacy, the mobile health, ubiquitous health, the artificial intelligence, machine learning, the big data analytics and robotics, the automation and personalized medicine. They have to know about the basics of these new skills and competences, and what's their uses in their specialties, and the opportunities that they have to improve the health of our population, and the challenges and ethical considerations that we have. In the Saudi Commission for Health Specialties, we framed the Saudi framework of the digital health or health informatics, and that include the leadership and management and the information competences, the education and research, and the health data analytics and the health sciences in general, and there is core principles. These are 6 domains, and there are 32 subdomains, including 120 competences that all healthcare providers should know about the coming digital health. For example, do we still to teach our medical students how to use this stethoscope in the clinic, while they can use such of these devices that are available, handheld just a handheld connected to their smartphones of ultrasound and echo. With artificial intelligence, could give them a direct diagnosis. These are the healthcare, the digital health professional workforce that we have in Saudi. That's including 3,800 health informaticians, but 2,900 of them are in the technician's level or rank. But the road is not full of roses. We have got challenges. The main challenge, as said before, that need money, need investment. Yes, that is cost-effective in the long run, and that will reduce the medical errors and improve the efficiency and effectively, but it has an investment cost at the beginning. And we should consider the digital divide. So, for example, in the digital divide, that the unprivileged areas or countries, that they don't have the technologies that we have. And we have to think about the time of disasters. Where we don't have the technologies. So the technologies could go out of service at any time, and how we are going to deal with patients who hasn't got the digital literacy or capabilities to use this technology. And also, we have to consider the ethical considerations, including privacy and security of the big data, especially when we are dealing about the genomics. And also, that could cause the delay of seeking medical advice when the patients using the technology themselves. And the problem of the misinformation, especially in the Arabic content in the web, where many of that is garbage. 70% studies showed that 70% of the health information available in the web are non-evidence-based. And the commercial advertisements that could be available in the health resources. If you allow me just to finish with this short video clip, can you just raise the volume to end my presentation with?
تذكير موعد تطعيم ابنك خالد الساعة 10 صباح الغد.
طيب.
يفضل تعبئة استبيان النمو والتطور لخالد قبل زيارة المركز الصحي.
إن شاء الله.
لمزيد من المعلومات سيتم إرسال رابط موسوعة الملك عبد الله للمحتوى الصحي باللغة العربية.
شكراً.
عفواً. تذكير موعد ابنتك حنان للكشف الدوري للأسنان الثلاثاء القادم بالمركز الصحي الساعة 2 ظهراً.
أحتاج تغيير الموعد للأربعاء القادم بنفس الوقت.
تم تغيير الموعد حسب الطلب. يفضل تغيب ابنك سامي عن المدرسة غداً لأن لديه حساسية شديدة في الصدر، وحسب الأحوال الجوية سيكون هناك غبار كثيف.
طيب والعذر؟
سيتم إرسال مشهد بحالته الصحية إلى المدرسة آلياً عبر نظام الإجازات المرضية.
طيب لو تعب؟
يمكنك عبر تطبيق صحة أخذ الاستشارة الافتراضية مني أو من الطبيب.
زين والأدوية؟
يمكنك دوما المقارنة بين الخيارات المتاحة للأدوية عبر تطبيق بك نهتم.
نعيد تصميم وربط خدماتنا حسب احتياج المستفيد. خدمات صحية مترابطة.
Thank you for listening.
Thank you very much, Dr. Amr. This was really an illuminating talk. With this, we conclude our plenary session. Jum'ah prayer will be in front of the hotel at the masjid in front, and I think it